we're letting people just join slowly. So maybe I'll just start by saying good morning, good afternoon, and good evening, everyone. I'm Olive Kokeman for the Network for Improving the Quality of Care for Maternal, Newborn and Child Health. Welcome to our webinar. This is the first webinar in a series of lessons learned by the network countries in their efforts to build and institutionalize systems to sustain and scale up quality of care for maternal, newborn and child health. Today, we are going to hear from 3 of our countries that are part of the network countries that have been working hard together over the past number of years. We will be hearing from Ghana, and as the series progresses, we will hear from further countries who have been working to halve maternal and newborn mortality and improve the experience of care. It's the 31st of March. We are very, very much looking forward to hearing from Ghana today. On April 7th, we will have the lessons learned to be shared from the Ministry of Health Bangladesh. On April 13th, we will hear from Tanzania, improving quality of care at district level. And to end the series, on Tuesday the 4th, we will launch the network report that covers the period 2017 to 2020 for all the network countries, talking about the evolution, implementation, and progress. It's my pleasure to hand over to Dr. Tedbab Defige Hele Gabriel, who is Senior Advisor at Maternal and Newborn Health at UNICEF headquarters. And Tedbab will kick us off on the content and the presenters. Thank you, Tedbab, over to you.
Thank you, Olive, and I would like also to welcome everyone from wherever you are. Thank you for giving us this time. As Olive said, we will be sharing through series of this webinar an important lesson that countries have demonstrated in taking up quality as a priority agenda to change the trajectory of maternal and perinatal health outcomes in their countries. So today we will listen from Ghana's experience, how the country has, approached building systems to sustain and scale up quality of care for maternal, newborn, and child health. Specifically, we will hear today from district level experience in improving quality. I am co-facilitating this with my colleague, Dr. Roslyn, who is a National Program Officer at WHO Ghana Country Office. Dr. Roslyn, and I will be facilitating this session, as I said. Next slide. So we have today in this panel, as I said, myself and Dr. Roslyn will be co-facilitating, and we'll have 3 esteemed panelists from Ghana. Dr. Isabella Sagamosis is the Deputy Director of Family Health Division. Dr. Ernest Asedio, who is the Head of Quality of Management, and Dr. Priscilla Wobil, who is the Health Specialist at UNICEF Ghana. To you, Dr. Isabella, to introduce our panelists.
Thank you, Tedbab. Just to give a little brief about our esteemed panelists for the day. We have 3 seasoned speakers for today. Our first speaker will be Dr. Ernest Asiedu. He's the head of the Quality Management Unit at the Policy Planning, Monitoring and Evaluation Division of the Ministry of Health of Ghana. He has been very instrumental in supporting the development of several national policies and strategic documents. A key one is the National Healthcare Quality Strategy. And he's been in a number of quality improvement projects, and currently he's the country focal person for the Quality of Care Network from the Ministry of Health. Our second presenter will be Dr. Isabella Segobosis. I'm sure most of us have met her on other fora. She is the Deputy Director for Reproductive, Maternal and Child Health at the Family Health Division of the Ghana Health Service. She is the chairperson of the National Newborn Subcommittee, responsible for coordination and implementation of the National Newborn Health Strategy and Action Plan. She's a member of Ghana's National Steering Committee for Early Childhood Care and Development and Ghana's School Health Steering Committee. She's an experienced facilitator for WHO courses on INCI, infant and young child feeding, and other breastfeeding courses. This just to highlight her role in child health. She is the country focal person for the Quality of Care Network from the Ghana Health Service. Our third presenter is Dr. Priscilla Wobel, who is a consultant pediatrician and currently works with the UNICEF Ghana Country Office as a health specialist. She's the focal person for immunization and maternal, newborn, and child health, providing leadership and technical capacity for designing, planning, implementation, and monitoring of programs. She successfully led the implementation of the multi-country Bill and Melinda Gates funded maternal newborn quality of care program, also known as the Mother Baby Friendly Health Facility Initiative in the Upper East region of Ghana. Some key highlights of this initiative will be shared in this webinar. So we'll straight away call on our first presenter, Dr. Ernest Kunedu Asiedu from the Ministry of Health Ghana, to start with this presentation. Dr. Ernest, over to you.
Thank you very much, Rosalind, for this elaborate introduction. This presentation is going to be in 3 different parts, and I will start, and then my other colleagues will also do some presentations. At the end of the day, there'll be opportunity for Q&A where colleagues will make some inputs into. Next slide, please. So generally, we would look at some aspects of the maternal and newborn in terms of the challenges that over the years we have had in the past in terms of stagnation of neonatal and maternal mortality reduction. And then we also look at the opportunities that we are seeing at the moment within the country setting. Next slide, please. So generally, there are aspects of these are the 4 major strategic objectives that the Quality of Care Network hooks on. And the first one is looking at leadership, action, learning, and accountability. On my part, I will zoom a little bit into the leadership and accountability part. My colleagues would also present action and learning. But generally, I would say that the Quality of Care Network, which is a broad partnership of committed governments, and Ghana being a very strong part of this over the period. I think the launching was done sometime in 2017, which is looking at together with the implementing partners and then some funding agencies that are also supporting the good work we are doing for women and then also for a newborn as well as child. They are receiving quality care in relation to equity and dignity. Next slide, please. So we'll talk a little bit about the quality standards. And basically, we have 9 core standards to reduce maternal mortality and morbidity, and which are interlinked standards with the intent statements and criteria outlining the elements needed to meet the standards. And here we're looking more around the clinical care. We're looking at patient rights and then also some cross-cutting issues. And next slide. So this basically would be incorporated into aspects of provision of care, which is more focused on the provider side, and the experience of care, which is more focused on the consumer side. So I would look closely at some of the national strategies and engagements, and this is where leadership and accountability plays a critical role. Next slide, please. So you see this picture, the mother is smiling with a newborn. And I think efforts, in terms of becoming pregnant will ultimately lead to an outcome of having a live baby that is also going to grow beyond the age of 5. And this is something very important that we need to look at. Thank you. Next slide, please. So here we can see some health in Ghana. I would say that compared to some other countries, Ghana has made a lot of strides between the year 2007 and 2017, as has been reported in our maternal health survey. So we've been able to move up from 54 percentage points to 79 as far as skill delivery is concerned. And I would say that this is some very important strides that as a country we've been able to make. But then again, when you look at it, newborn mortality is concerned. Currently in the country, we're playing around 25 newborn mortality per 1,000 life. Next slide, please. This clearly tells us a little bit about things related to the quality of care. Even though access in terms of coverage is quite okay, we need to also have a little focus on the quality of the services that are being provided. So I'll quickly move on to the leadership and accountability related issues. And I will be talking about how this fits clearly into what we call the National Healthcare Quality Strategy. And that has the first objective looking at governance and leadership with establishment of quality governance systems in place. So I would want to talk a little bit about some of the systems that we've been able to. Leadership is everything as far as these quality safety initiatives are concerned. So at the level of the ministry, for example, we've national leadership or national dialogues. There are opportunities for different kinds of summits, like the health summit and various quality summits that are being organized from time to time, involving stakeholders and partners. We also have what we call the National Healthcare Quality Strategy that is guiding all the quality sector. In addition to that, we have the National Operational Plan for Maternal and Newborn Health, Quality of Care, and the roadmap which we developed in the country. Some of these ones also emanated from teasing out the implementation of the National Healthcare Quality Strategy, the Quality of Care Network. And during this period, various agencies have been empowered to develop specific operational guidelines to be able to implement this strategy, which is a policy document from the Ministry of Health. I would say that the Ghana Health Service, which is the major public health institution as far as service, similarly, we've been able to adapt to the WHO standards for improving quality of care in the facilities based on each country's contextual related issues that are there. In Ghana, we have what we call the implementation guide. We've developed some tools that helping us to implement the standards that we all developed together. Specifically, we also have what we call the National Productive Maternal, Newborn, Child, Adolescent Health and Nutrition Strategic Plan, which is 2021 to 2026, with some quality of care being the pivot or the fulcrum of what we. So continuing, next slide, please. Continuing. There's been the inclusion of the newborn care standards in the National Health Insurance Authority credentialing tool. These are very strong tools as far as the payer is concerned to ensure that at least the minimum basic requirements as far as quality of care is concerned are being adhered to before the payer would pay for services that the service delivery agency has provided. In addition to that, the Health Facility Regulatory Agency has also developed what we call the assessment tool, and we have some of the inclusion of these newborn care standards in there. Now, the Health Facility Regulatory Agency is the main accreditation agency within the country that licenses and relicenses and accredits facilities. And so the minimum requirement for establishing a health facility must necessarily include some maternal and newborn indicators so that we can provide quality care. Again, we have the regulatory bodies that are also fully involved as far, and then also the professional associations, including, for example, every health professional within the country must be licensed to be able to practice, for which reason, year on year, every health professional is supposed to be in good standing to be able to provide quality care. Out of these things, there would be some CPDs, continuous professional development programs that are organized, and this would lead to the professional being licensed by, for example, the Nurses and Midwifery Council, the Medical and Dental Council, just to mention a few. as well as the various associations that are also formed. For example, the Pediatric Society of Ghana and that of the Obstetrician and Gynecologists also having some focus in partnership with maternal care. We have also, on the other side, from the experience of care perspective, developed what we call the community scorecard. And this was launched in January 2018. That has been very strong as far as our experience of care network is concerned, giving the power to the community, using the community health management committees to be able to provide feedback and to be able to come up with some action plans and to provide some aspects of healthcare and to complement the work of the service delivery agencies and the health sector as it were. Next slide. This has also given the opportunity for the community to make impact as far as provision of care is concerned, and also some effort in supporting the healthcare system. They've been very strong in things around building some walls around the place, making inputs into specific initiatives, making donations of equipment to the facilities to be used. Again, we have what we call, scaling it down a little bit, we have what we call the technical working group, which is currently very functional and meets every quarter. It's a partnership and co-chaired by the Ministry of Health and the Ghana Health Service. And this is from the Family Health Division. This is co-chaired by Dr. Isabella Segunosis and myself. Again, the Institutional Care Division of the Ghana Health Service, out of the development again of the guidelines to operationalize it, together with the health of the Ghana Health Service and the policy planning, monitoring and evaluation of the Ghana Health Service as major members of the technical working group. In fact, all the data that we work with are being collected, and the learning and reporting related issues are also being supported by the Research and Development Division. Now, we also have other service delivery agencies like the Christian Health Association of Ghana, together with Ahmadiyya, which are the faith-based institutions. We also have what we call the Ghana Association of Quasi-Health Institutions. These are health institutions that do not necessarily belong to the provide service, their own staff, and for that matter, also extend to the general public. And then a chunk of it is also the self-financing private health institutions. And recently, as part of a study that was Nigeria and Bangladesh, to be able to have a better understanding of how the private sector's role impacts on maternal and newborn care. And if you all know, as part of the UHC and then also the Sustainable Development Goal 3, we are leaving no one behind, for which reason I've made some deliberate effort to ensure that all service delivery agencies, including the community and self-financing, play a critical role for us to move the country to the destination where we are. And we've got our own roadmap. ICA, Ebola Institute for Healthcare Improvement, Jamaica, PATH, MEPSI, USAID, and just to mention a few. Next slide, please. So on the national scale up, I just want to, this is going to be my last slide, but just to go back a little bit and to say that with the introduction of the country, we going back a little bit in time, and when we started, we got support from UNICEF. Ebola also supported the Greater Accra region, and we started this. But I must say that between the 2016 and then also ultimately, and up until now, we've been able to scale up within the country to cover a number of regions. So currently, I would say that the joint partnership between UNICEF and WHO supporting Ghana, and for that matter, the Ghana Health Service at the operational level, together with the other agencies that are on board. Currently, we have 5 network regions that our intention is to learn and gather a lot of lessons from this to be able to make it a national. Ghana has been able to split a few are currently part of the network. So on that note, I think that my part of the presentation will come and then we will continue, and I will invite my colleague to take over. Thank you very much. Next slide, please.
Thank you very much, Ernest. So for the next few slides, I'll be talking about action and learning, and it would focus more on the initial pilot region where we started implementing the Maternal and Newborn Quality of Care program. And we'll look at some of the findings that came out of the assessment that was done following the implementation between 2016 and 2018. Next slide. Yeah, so the focus of the Every Mother, Every Newborn Quality Improvement Initiative aims to reduce maternal, newborn, and stillbirths, and then also severe morbidity, increase access to services, and then ensure safety of mothers and newborns. And before the WHO quality of care standards were launched, the Every Mother, Every Newborn, which we call EMN standards, were implemented in these in this pilot region. And so that is why you would hear EMN, Every Mother, Every Newborn, but it's the same standards of care, and there's no difference. It's just that the EMN standards were developed and implemented before the WHO quality of care standards were developed, but they are the same. They are the same standards. Next slide. So what were the intervention packages for this implementation? So it cut across infrastructure where kangaroo mother care units and level 2 newborn care units were established in 3 hospitals, and newborn care corners, basically resuscitation areas in health centers. Emergency obstetric equipment were procured to support home visits and then community outreach services to ensure continuity of care. Motorbikes were also procured, and then wash infrastructure was improved. Washrooms were built for maternity units that did not have washrooms for their mothers who had come to deliver, and it also included mechanization of boreholes. And the other major component was also strengthening the quality improvement teams within the facilities and also at the district levels. And training, mentorship, coaching was done for these teams in all the implementing districts and facilities. Perinatal death audits were very key, and staff capacity was built in how to conduct these audits and then implement the recommendations thereafter. The others cut across infection prevention, labor monitoring, community engagement, ensuring privacy. So the facilities reorganized their labor wards to ensure privacy for the mothers who come in labor, triage, referrals. All these are things that are already part of the services that we are supposed to be providing as far as maternal and newborn care is concerned. But what changed was the quality of these services. That is what was the focus in all these interventions. Next slide. So the assessment was done in 4 intervention facilities and 4 comparison health facilities. Just to state that the intervention took place in 24 implementing facilities, 3 hospitals, and 21 health centers in 4 districts. Next slide. Okay, so there were 4 main objectives. The first one looked at the structural readiness, human resource, healthcare provider skills, equipment, and then supplies. The second objective focused on determining the extent to which the QI standards had been institutionalized within the facilities. The third objective examined improvements in perinatal clinical outcomes, because when you implement the standards, you expect to see improvements in the clinical perinatal outcomes. And then the last one was more on documentation and describing the lessons learned from the implementation of the quality of care model. Next slide. So what were our findings? So broadly, the implementation period was for 18 months, and in the intervention facilities, there were over 31,000 births recorded. And in the 3 hospitals that the newborn care units were established, there were over 4,800 newborn admissions. So that's sick newborns who were admitted. And then there were 18 mentorship visits, which were done with support from specialists in pediatrics, obstetrics. And then there were 32 QI coaching visits, and these were done by the regional and district quality improvement coaches. Next slide. Yeah, so there were some innovations, and you see the nurse with holding 3 colored bracelets. So these were used at the obstetric triage units, and it was purposefully to identify women requiring immediate attention to prevent morbidity, severe morbidity, and then death. So the red bracelets were put on the wrists of mothers who came in with severe complications. And so once a woman has a red bracelet, it means she requires immediate attention. And the yellow ones were for those who came in with complications, but you could provide care they could wait for at least 15 minutes. And for the green ones were for uncomplicated labor cases that came in. Next slide. So on intrapartum care, we noticed that before, so the baseline assessment was done, and then the intervention, and then the follow-on assessment. So what we found before, so at baseline, was that there was high coverage of some interventions during the intrapartum period. You see on the graphs where fetal hearts auscultated, patograph use, oxytocin administered, etc. So the before charts bars are the lighter blue, and then the after are the darker blue colors. And you see that there was high coverage of some interventions. However, after the implementation, we noticed that there was substantial increase in documentation. So documentation improved remarkably, and you see the difference in the second chart where you see very, very high coverages, and it was mainly the documentation of interventions that were provided increased remarkably. Next slide. Then on newborn care, again, there was high coverage of newborn care at baseline, and the establishment of the newborn care units with the training on various aspects of newborn care helped to increase or improve the quality of care, especially at the time of birth. We saw a slight decline in skin to skin by 3%, but it was generally very high across all the newborn care interventions. Next slide. On respectful care as well, there was improvements in all the 3 domains: effective communication, emotional support, respectful care devoid of abuses. We saw improvements across all the domains. So women felt treated with respect, women consented for their C-section, they were informed, delivery plan discussed, told examination findings. We saw improvements across all these areas. Next slide. But we noticed that some of the improvements were very marginal, and in some we saw some declines, but we see that the program has offered opportunities for improvements, improving further on these in these areas, specifically on respectful care, which is very key as far as improving survival of mothers and newborns are concerned. And we see that even early initiation of breastfeeding is part of respectful care for the baby and as well as the mother. So we see that this program has offered this opportunity for us to take a second look at how we can strengthen and improve respectful care along the continuum of care. Next slide. Yeah, so we noticed at the end that there were 3 main standards that need further improvements: Standard 5, which is more on respect and preservation of dignity of care. And the standard 6, more on emotional support for mothers, which we realize that needs further improvement. Currently, the Ghana Health Service is conducting a study on to study the psychosocial impact of perinatal deaths on mothers and families. And I think this is going to help to develop some guidelines for improving or supporting women or mothers and families who face adverse events during labor and then after birth. The standard 6 is also standard 8, sorry, is more looking more at the physical environment, water, sanitation and hygiene facilities, essential drugs, medicines, and equipment for routine care for mothers and newborns. And we realize that this 8th standard also would require further improvements from the assessment that was done. Next slide. So what was the effect on mortality? So we would say, looking at the graph, we would see that mortality fell from 19.6 per 1,000 total births to 16.2. And this was a decline by 17%. We also noticed that there was a decrease in the neonatal case fatality rates from 8.3% to 4.5%. This was in the newborn care units that were established. And we started in 2016, but we noticed that in 2017, there was a rise in the deaths, and this was due to improved data capture. But as the quality of care interventions were intensified, we began to see the decline. Next slide. So I will now hand over to Dr. Sego Moses, who would share the lessons learned, recommendations, and the conclusion. Over to you, Dr. Sego Moses.
Thank you very much, Priscilla. So we have learned a number of lessons over the years, and I will share some key ones with you today. The first lesson is that quality improvement interventions do save lives. As Priscilla presented on, I think, her last but one slide, showed the downward trend in perinatal mortality over the period. And so this quality improvement interventions should be the thrust for achieving sustainable reductions in maternal, stillbirth, and newborn mortality. Next slide, please. The second lesson has to do with leadership. And we are talking about leadership at all levels of the health delivery system, right from the national level to the lowest level of service delivery. Leadership is key to the success of QI initiatives, and the various levels must work synergistically at this. Next slide, please. Also, we learned that fully integrated QI coaching models allow for expertise in higher level facilities to support care at all levels, especially in settings such as ours, where access to specialized care is not always available. So having specialists from the higher levels coaching the lower levels and giving them support is very critical for QI initiatives to succeed. Next. Next slide, please. The other lesson is to do with data. Data quality improves, as we saw in our case, when QI models QI interventions are implemented. And early improvements in care may be masked by the improvement in data collection. So initially, it appeared as if we were not making any inroads. It actually appeared as if our indicators were going the negative way. But that was because of improvement in data capture. And so as implementation continued, then we began to see the dips that we were looking out for. So it's important not to get discouraged and persist with the initiatives to be able to see the needed change. Next. The fifth lesson is that quality of care should actually be the entry point for wider health systems improvement. It gives us the opportunity to address in a holistic manner the health system gaps that will help us to provide care that will lead to the impacts that we all want. Next slide, please. Now to some recommendations. These are recommendations that we made in country after implementing the initiative for about 5 years. So the first recommendation goes to the Ministry of Health and the Ghana Health Service and the Quality Directorate to facilitate rollout of QI packages across all facilities after we had seen the very marked improvement after implementing the QI initiatives. So this is talking about scale up. And then secondly, capital investment and engagement with key partners is very necessary to build capacity, procure key inputs, and strengthen support for data use. So the whole aspect of the environment where we deliver care being improved, with all partners being engaged to do this. The other one is a recommendation to integrate perinatal death surveillance data and analytical automations into our health information management system. We see that when everyone knows that we are looking at the data, it's being brought up to the highest level, then efforts are made to improve the indicators. So perinatal death surveillance is necessary to be integrated throughout the system. And then there's additional support needed to strengthen regional oversight and facility capacity in order that key QI components such as maternal and perinatal death surveillance reviews are done. So at the regional level, the district level, down to the facility level, it's important to support these activities so that they are done regularly and the recommendations are followed through. Next slide, please. Tapering of key support from partners must be gradual. Sometimes when we see good results, then we are so happy and the support immediately dwindles. But it takes time for Ghana Health Service and for that matter, the public sector to build capacity and to now dwell on their own resources to keep up the momentum. So this recommendation is to our partners not to leave us alone immediately, but to gradually wean us off so that we can sustain the gains that are made. And then the other recommendation is for Ghana Health Service, the ministry, and partners to explore opportunities to disseminate these best practices. And we have done so through existing fora that we hold regularly at various levels, starting from the national level to the district level, to share these best practices. And by doing so, already other regions and facilities have picked up on some of the initiatives and are also implementing. This is very a critical priority in the immediate to medium term. Next slide, please. So in conclusion, we want to reiterate the fact that implementing the quality of care standards is feasible, as I believe we have demonstrated in Ghana. which is one of the middle income countries. So it is possible. And implementing quality of care standards in facility is necessary to improve health outcomes. It's important to sustain results and scale up, but this will require system-wide changes and significant and continuous technical support. Thank you for your attention. May I hand over to TEDBAB?
Thank you, Dr. Isabella, for this excellent presentation. All the panelists, you have taken us how the idea started as a pilot, and also concurrently system-wide changes and systems were in place to ensure the government's ownership, leadership, and also putting the system within even the accreditation system, and also the human resource development and career development system. So thank you for sharing this remarkable experience. This implementation was done with a number of partners within Ghana and also at global level. And this was done with the generous support from Bill and Melinda Gates Foundation. And we would like, to acknowledge these partners. So now participants also, thank you so much for your active engagement. The chat box is really busy. We have really excellent questions. So now I will invite the panelists to respond. So first, there was the first question. Whoever has, the information can come in, but I think it's mostly for Ghana Health Service. This is how you manage the motorbike that was put in place. So the question was, how was it managed in terms of fuel maintenance? So if you can take that one, and then I will read the other questions as well for you. So who will take this? How the motorbikes for community outreach were managed? Would this
Yes,
be?
I would answer the question.
Okay.
Yeah, so it was managed by the district health management team, and the fueling, the maintenance, this was done by the districts and the facilities. So UNICEF just procured it and gave it to them, but they maintained it, they fueled it. Over.
Thank you. And then we have another question from Christina. Christina actually has two questions. One is pertaining to know what measures have been put in place to ensure sustainability. Actually, other colleagues also have that question. So, Dr. Isabella, if you could respond, the sustainability measures that are in place in general, both for Christina and other colleagues. Back to you, Dr. Isabella.
All right, thank you. So all that was done was within our system, quality improvement system. So we have a national quality strategy that the Ministry of Health and its agencies adhere to. And in the Ghana Health Service, we also have an implementation strategy. So every agency is enjoined to have an implementation strategy to make sure that the national quality strategy is implemented. And there are structures that are laid out right from the national level down to the facility level, ensuring that the management system structure is clear and who should be doing what at every level. And so it is the same system that we utilized. So the region knows what its responsibility should be, the district knows, and the facility knows who should be working and who should be reporting. So that is the first thing. So we all know that it is part of our job. And also the facilities and managers are all encouraged to support quality improvement through the funding that we receive for service delivery. So even without external support, we try to mobilize support from our Ghana government funding to implement these activities. Another key part is the accountability part. And so quality improvement reporting is part of the health information system, but it's also part of the various review meetings that we undertake on a yearly and half-yearly basis. So we have district review meetings, we have regional review meetings, and then we have at the national level review meetings for various divisions and then for Ghana Health Service. And quality improvement reporting is part of all this. And we try, as I said earlier on, to also showcase the efforts that are being made and the results that are being achieved through some of these fora, as well as special fora like our newborn conference, which we hold yearly. And this serves as motivation for other facilities to copy and replicate the best practices. Thank you.
Thank you, Dr. Isabella. So the next, another question from Christina is regarding implementation framework or models used for implementing this QI program. So Dr. Alex Manu will respond to this question.
Thank you very much, Tedbab. So the implementation of the event QI was hinging a lot on the evidence that was available at the time that this was done, and this was from 2016. And one of the successful things that was done in Ghana prior to that was the IHI implementation of quality improvement in waves in some parts of Ghana. And so the models around the PDSA cycles and continuous learning to improve the quality were the models that were used. The other things that I would say supported the outcomes that were seen during the implementation were the components around coaching and the mentoring process. Now, what was done was that an online platform was used to continuously follow up on these coaching and also to support the sites in the review of the deaths and mortality outcomes. So with all these supports that were coming from the various experts who could not always be there physically to support the facilities, they supported the quality that was delivered, and there was a continuous feeling among the implementation personnel and facilities that support was immediately available, and this really enhanced the success seen. And then the other thing was that everything was led by the facilities. So most of the times, the leadership, the direction around what should be done and what is lacking behind was always led by the facilities. And so the Ghana Health Service continually had that leadership in implementing these. And so if you ask whether there was a particular framework that was used, I would say that it is the normal PDSA cycles, the coaching and the mentoring, and then rigorous mortality reviews to inform implementation. Thank you. Over.
Can I add something, Tedbab?
Yeah,
Yes,
go ahead.
Yeah, the other thing that was done was following the baseline assessment findings. Before the intervention or the implementation, the Ghana Health Service with the Ministry of Health developed the National Mother Baby Friendly Health Facility Initiative implementation guidelines. So all that Alex has talked about was incorporated into these guidelines, and that is what served, that is what was used to guide implementation. Over.
Thank you, Priscilla and Alex. So we have another question from Jeffrey. Jeffrey's question is, were there any challenges, particularly in the scale-up process? Managing the increasing activities as more facilities were involved, and what advice do you have for governments or institutions who are planning to scale up their own programs? So any of the panelists could take this.
I think that one challenge that we have grappled with is that of human resource capacity. To be able to stay on and do the coaching and the mentoring amidst all the other things that one has to do. And so one way of getting around it is to be able to get people who will focus on it, whose maybe core business is QI. So the way our system works, because we have a quality institutional care division with quality improvement as one of their key mandates. There's a deputy director there that is responsible. And then in the regions, there are deputy directors for clinical care whose also core business is quality improvement. So they are able to focus. But then for the mentoring and coaching, sometimes you may even have to go outside a particular region. For example, in the Upper East region, pediatricians were not available. So we used pediatricians from a neighboring region to support them. So sometimes you'd have to go outside the particular region to get support to do some of the visits and some of the engagements from afar to help with the implementation. So that is one challenge that I would like to talk about.
Thank you, Dr. Isabella. So we have a lot of questions to cover. So let me rush in. So Lee has a question on QI coaching, collaborative data generation and use. As we all know, this requires resources to sustain. So has the government allocated financing for these functions in the budget? Maybe Dr. Isabella, you can take this.
Can you please repeat that? And
So,
maybe Ernest can also help.
Yeah, quality improvement, that includes, all the coaching, collaboratives, and the data generation and use requires resources to sustain this. And has the government allocated financing for these functions in the budget? You have touched it a bit in your earlier message, on your earlier response on sustainability, but this one is specific for financing. It's just to make sure, to see if there is a government allocation in the finance for specifically for this.
Okay, so because we have policy documents and strategy documents that lay such emphasis on QI, advocacy for financing, we have the tools to advocate. And so we keep advocating. And of course, we also not just depend on government, but also support from our implementing partners. And because these things are well spelled out in our documents, it's very easy to show that this is government priority. But above that, as I said earlier, it is part of our core business. So the government of Ghana monies that come to us for implementation. For example, the question that came earlier about how the motorbikes are maintained.
Yeah.
We have our service votes that go to districts, and to facilities. And so these are all used in pursuing the QI initiatives. Also for the health facilities, especially the bigger ones that have internally generated funds, they are encouraged to use these internally generated funds to support QI initiatives. And one recommendation or provision that has been made currently in our Ghana Health Service implementation guidelines is that the head of the facility should be part of the QI team.
Yeah.
So it is not now that some small committee in the facility is going to, make demands. If the head of the facility is part of the committee and actually the head of the QI committee for the facility, then they make sure that whatever recommendations are made are implemented. And beyond the bigger committee, QI committee for the facility, there are, the recommendation is to have committees for various departments. So for example, the maternity unit will have a committee there that looks at QI, maybe 1 or 2 people, the pediatrics the same, but then they all work towards the head of the institution. And where internally generated funds are available, the head has all to say to, agree that such funds should be used where needed. Thank you.
Thank you, Dr. Isabella. So before we end, we have 4 minutes. I would like to address 2 questions. One is regarding, the mortality from EO. So his question is, was the reduction of perinatal mortality from pilot facilities or collective from scaled up regions? How long it has taken for the reduction? So maybe Priscilla, you take this one quickly, and I will take up, one question from one colleague who has 2 questions.
I didn't hear you very well, but I think the question has to do with the perinatal mortality reduction.
Yes.
Yes. So
yeah.
Yeah. So the reduction, this was in the 17% reduction was in the intervention facilities. In the comparison facilities, there was some reduction, but not as much as the 17% that we saw in the intervention facilities. Just to say that whilst UNICEF was supporting the Ghana Health Service to implement this program, the other interventions as far as the maternal newborn care is concerned continued in the whole region. The region had support from other partners. And so even those who were not part of the intervention facilities, so more like the comparison facilities, also had some support from other partners to improve on the quality of care that they were providing. So there was some reduction in mortality there, but it was very minimal, and the change was not significant as far as the comparison facilities were concerned. So that is what I would say for that. Over.
Thank you. So the last, maybe let's stop here because we just have 1 minute. So what we will do is, Olive, if you put up the last slide. Again, thank you, colleagues, for this active engagement. This is very lively conversation. This is not the end. We have a number of opportunities to stay engaged. As we said, there are upcoming webinars. Wednesday, April 7, we will hear from Bangladesh how they build the quality of care system in scale up. And also on Tuesday 13, we will hear again from Tanzania district level implementation. And on May 4, as we see here, the report from the network will be launched, and that will somehow, conclude this specific series. But there are also, places where you can learn more about this opportunity. We have provided the link, and also join the quality of care, the community of practice. In this community of practice, we will make sure that we will respond to your questions, which we didn't have sufficient time to do now. Again, thank you so much for your precious time. As we have, learned from Ghana, I would like us to go, with three main messages. One, as we all have seen now in low and middle income countries, quality gap is now major driver for mortality. Access is not. How do we know that? More and more women are delivering in facilities, receiving antenatal care, but a reduction in perinatal mortality is not in par with that. There is a huge quality gap. And second is, if there is intentional effort by partners and also government leadership and ownership to address this quality gap, it is possible to improve quality, and that quality improvement results in mortality reduction. Number three, to sustain that gain or to achieve that quality, there needs to be a system-wide support, a system-wide approach, a system-wide investment. And there needs to be, this collaborative learning, continuous learning, and continuous technical assistance. As you all are, champions for maternal newborn health and address quality, I would like us, to keep engaged and keep the conversation. Again, thank you very much. And you can review also, as Olive writes in the message, look at the network's website for more resources and upcoming webinars. Thank you very much. And have a good day.
Thank you all.
Very much.
And the UK is looking for a skill, and Ghana doesn't even have enough of those skills. I don't think that an agreement to compare Ghana